Start earlier.
Robbed another drug dealer.
Yeah.
You know, so they were. Oh,
But there is.
Yeah.
It's a great game. Got each other.
Hello, hello. Good morning, everyone. I think we are ready. Can you hear me? Yes. We are ready to start. It is my great pleasure to introduce you to Dr. Jordan Reynolds. He's a good friend and a colleague. We worked together for 7 years at the Cleveland Clinic. He's a native of Ohio. And Jordan did his medical school at Northeast Ohio Medical University. Then he did an internship in general surgery at Case Western University. And after that, he did a residency in anatomic and clinical pathology at University of Cincinnati, where he was chief resident. So he started with leadership since a resident. He then did a fellowship on surgical pathology at Mayo Clinic, followed by another fellowship in cytopathology. And then after that, he joined the Cleveland Clinic in 2011. So we overlapped for 7 years, worked together. Not only is he a fantastic general pathologist and cytopathologist, he's also very innovative. He's been involved very much with a lot of training, mentoring. He's done a lot of publication also in research, particularly related to cytopathology. But the reason why we collaborated because he was also covering genitourinary. So he's also a GU pathologist. And that's one of the reasons why I like him even more. So now, things that I did not know about him is that he's also a very accomplished piano player. And he does actually play the organ. He also coaches softball. He does a lot of other things, enjoys his family, has 3 beautiful daughters, and is super effective and very well, accomplished. He has done a lot of things also for training, created a lot of content, and really enjoys working with residents and fellows. So we're very much looking forward to your talk, and I'm so glad that you came and visit us in Birmingham. Thank you for being here, Jordan.
Well, thank you for that very flattering introduction. I'm honored to be here. I've heard so many good things about UAB, especially after I heard that you came here and Dr. Neto came. I keep reading about the department and what a great place it is. So I'm here today to talk about cytology adequacy, the current and future implications on the role of artificial intelligence. So I don't have any financial disclosures yet, maybe one day, but I'm doing this so I'm interested in. I'm not in it for the bag. So we'll review the role, scope, and philosophy of cytology adequacy as it pertains to a pathologist, describe the present state of adequacy, and predict the future of adequacy. Now, it's a very long talk, and I did cover quite a bit with the residents this morning. So we already talked about examples of how cytology clues can help guide IHC workup and talk about pitfalls in the diagnosis of small biopsy specimens. So I kind of got involved with this because I've been teaching adequacy for a long time. So prior to Mayo, I was involved with the cytopathology fellowship program for 10 years at Cleveland Clinic. I was a program director for 5. And our team taught over 30 fellows and 80 residents adequacy. And I don't know if you guys have been on adequacy, but it's, you look at the slide, you show the resident the slide, and maybe they look at the slide and you say, oh, that's right, that's adenocarcinoma, or if they got it wrong, you tell them why. So I kind of have some insight onto, teaching adequacy. And we give didactic lectures about specific procedures, EBUS, EUS, CT, INR, peripheral FNA, at institutional and large meetings. So I've been writing about these things for a long time. And we practice in the adequacy suite, and we do competencies, we give direct feedback to the clinicians. And I would say that it takes about 3 or 4 procedures and 2 or 3 examples for each kind of diagnosis for the fellow to be really comfortable on their own. So fellow comes in July, they're learning the system, and by mid-August, they start to get a grip of what's going on. And by October, I feel pretty comfortable leaving them, like showing up a little bit late, but we would always go down so that way we could try to bill for it. So I kind of cover this from the who, what, where, when, why perspective. So who's responsible for adequacy? And it really varies by available resources and by the medical center. So sometimes, at Cleveland Clinic, it was the board certified cytopathologist. Sometimes it's just an anatomic pathologist, or it could be a cytotech. It could be the performing clinician. You could have telecytology, and perhaps we need to start thinking about using artificial intelligence for this. What is adequacy? Well, it means different things for different people. So is there enough tissue that's adequate? Well, adequate for what? In the thyroid, they really just want to know that they have follicles, because they don't want to, the endocrinologist doesn't want a non-diagnostic biopsy to come back and the patient has to repeat getting a needle in the neck. For EBUS, adequate for what? Enough lymphocytes, enough tumor. And then you have to say to yourself, adequate means enough, but enough for what? Is it enough to make a diagnosis? In 2023, that's really not enough anymore. Can you definitively subtype a tumor? And do you have enough to perform ancillary testing? Where do we perform adequacy? There's an inpatient, outpatient aspect to this. Inpatient is usually the operating room, the endoscopy suite, interventional radiology. Sometimes you go to the patient floor or the ICU. Where outpatient, it could be a physician office like an ENT or a breast clinic or a cancer center. Sometimes there's these freestanding FNA clinics. They could be run by a pathologist, or they could be run by a head and neck people, or maybe a freestanding radiology center. When do we do adequacy? It depends on the situation and availability, which is becoming short for many of us. So pre-diagnostic is the situation where, the patient comes to your clinic and they're like, I got a lump. And you're like, okay, well, how long have you had this? Does it hurt? Who noticed it? You ask a lot of questions, there's no workup. Or maybe it's diagnostic where the workup is done and they need to know the answer. And the FNA is the answer. So, they do the thyroid nodule. They already got the ultrasound. The radiologist gave a TIRAD score and they're ready to do the FNA. Or it could be post-diagnostic. So you already know the diagnosis, but they need more tissue. Maybe they need to repeat the procedure. Maybe they need more for new studies, or maybe there's a metastasis or a suspected recurrence and you have to repeat the biopsy. What about available hours? We're not normally known as a 24/7 specialty. So 8 to 5, weekdays only. What about weekend availability? What if somebody really important comes and they need something? Then what do you do? Like, what if some big shot comes by and they want it on Sunday? What do you do? Well, why is adequacy needed? Well, it benefits the patient, and there's a benefit to healthcare. So from the patient perspective, you can get an immediate diagnosis. You can ensure diagnostic tissue is obtained and handled correctly. You can reduce the possibility of a fruitless biopsy and secure tissue for extra testing. And from the clinician perspective, is to reassure that lesional tissue was obtained and that tissue will be handled correctly. Where are the cytotechs in the room? Are there any here? Yeah. So, the cytotechs are often the lab. Like, for some of these people, that's who the lab is. You show up in your blues and then they're like, take the specimen down to, instead of tube it, they're like, take all this micro everything. So you're the representation of the lab, and they feel reassured that it's on your card, it's in your hands, it's going to be handled correctly. It's really reassuring. And sometimes it's too much. Like, they call you for something that's not cytology, and you're like, well, we just wanted the lab to come get it. We're cyto, we're not the lab. And there's a benefit to the healthcare system. So you reduce unneeded patient visits because it's non-diagnostic. It prevents delay in treatment related comorbidities, and it can bring patients into your system, especially if they didn't have access. Sometimes access is just the issue, like they need a referral to get in, there's a long wait time, but you get a pathology report and then there's a doctor attached to it. They're off to the races and getting treated. Let's dive a little bit into each W. So for the WHO, I was on this American Society of Cytopathology committee, and we did a survey on objective and subjective perceptions about rapid on-site evaluation. We wrote a couple papers about it. So who performs ROEs? Well, in academic medical centers such as this, usually it's a cytotech with a cytopathologist. Sometimes there's cytotech alone. That's how it is at Mayo Clinic, Florida. Cytopath and cytotech was what we did at Cleveland Clinic. Cytopathologist alone, I think you guys are somewhat doing that right now, or maybe with a resident because there's no fellow. Some people will send the cyto fellow alone, or no single dominant modality. In community practice, it seems to have the same distribution, although there seems to be a little bit more cytopathologists alone. For reference, commercial lab, I don't know how many people are doing rows there, but usually cytopath and cytotech. And we always got to include the Fed. They tend to use the cytopath and cytotech method. So why would we have a cytopathologist do it? Well, fellowship offers for intense training for adequacy. They get to a lot of experience dealing with these slides. They can offer a specific diagnosis and correctly triage the specimen. So you can say, this is non-small cell carcinoma. Let's get some more for NGS. Or you can say, this is a lymphoma. Let's do some for flow. They have a lot of experience with air-dried smears and alcohol-fixed Papa-Nicolau smears. There are some anatomic pathologists who just don't want to look at a diff quick. That's not their thing. Residency usually get 3 months of cytology training, and this could be a variable experience. But fellowship, you get 9 months of cytology training, and you usually get 2 months for elective and 1 month for vacation. But it's also a chance for journal clubs to join societies, case studies, participate in these things. And it provides that comfort level that not every pathologist is used to. I'm sure there's some people in your department where you could bring a cord to, but they don't want to be bothered with the smears. And that's understandable. Sometimes I don't. Anatomic pathologist performed is an excellent option. So now I work in a place where we have surgical pathologists who sign out cytology, and they do a really good job. They're board certified, they're taking the mock examinations, there's cytology on it, so they're keeping up. And each organ system has a different process of how to make the diagnosis, and anatomic pathologists know how to do that, especially if you're general, like if you're doing lung, thyroid, pancreas, you know exactly which path to go down and make a diagnosis. So they're very capable of doing this. The cytotechnologist is a good option. They can say if it's adequate, but they're not really supposed to render a further diagnosis than that. Sometimes the clinician will press them for it, and you may or may not say something. And there seems to be this unspoken dialogue based on the triage you ask. So you say it's adequate. Give me an RPMI for flow cytometry. They'll say, they might think this is lymphoma. Or if you ask, this is adequate, you better get some more so we could do next generation sequencing. They'll say, this must be cancer. Or if you say, let's get some for cultures of granuloma. So there's an unspoken diagnosis you're providing to them. But there's increasing procedures. There's more time, there's more FTE needed to do this. And, this is a tertiary care center, and there's lots of hospitals out here that don't have EBUS, and they may not have like robust advanced endoscopy. So they're sending people here. And like if somebody has mediastinal adenopathy, they have to come here, they got to get worked up. And we're finding that the workforce shortage is critical at this point. Currently, there's only 20 cytotech schools from the Commission on Accredited and Allied Health Education Programs. And this is in 2022, the 2020 vacancy survey from the ASCP came out. And they say of all the lab vacancies, there's about a 4% vacancy rate for cytologists in 2020. That was right when the pandemic was reaching its peak. But more alarming is the anticipated 5-year retirement for cytotechnologists is 17%. And I'm sure that's been accelerated more. And there's a lack of cytotech schools. So as we start to lose cytotechs, what are we going to do? I mean, it takes a while to train them. It takes a while to get them up to speed. We have a clinical rotation where people can come train with us, and we set it up for education, but really it's to get people in the system, because we have 2 cytotechs that are could retire at any time. But they love their job and they love what they do, so they're sticking around for a little bit, but it's coming. Clinician performed is really not ideal. They're not cytohistomorphologists. And also it takes time away from them caring for the patient and doing what they can do, which is perform procedures, perform surgeries. It may not be worth having them spend $60,000 on a microscope, even if they can perform a limited degree of microscopy. So clinicians don't do that here, do they? No. Well, there's a little bit of data on it, and it's from a group in Italy. And here they talk about, a trained pulmonologist can reliably assess lymph node samples. And, the data here is okay, but unfortunately, if you look at table 4 here, the pathologist called, of these 155 lymph nodes, they called 10 reactive, and the pulmonologist called these malignant. If I did that 10 times, I think I might have done that 1 time in 10 years. During the procedure, I'll go ask for help if I need help, but I've only made like 1 big mistake like that in 10 years. If I did that 10 times, like I would not be doing cytology anymore. It's not acceptable for us. And then here on the other side, if a pulmonologist, called it malignant and we called 10 of these reactive lymph nodes, again, that is not acceptable for a pathologist to do. And I would argue it's not acceptable for them to do. So they can do it, but it's just, the sensitivity and specificity looks good, but it's quite unacceptable. And then they even talk about how they're able to collect an adequate amount of data or of material for next-gen sequencing. So, we had a molecular pathologist and a pulmonologist and pathologist agree. And there is some congruence here, but I think that we're better off leaving these to the pathologist and the molecular pathologist rather than leave it to the pulmonologist on whether something is sufficient or insufficient. So they can do it, but I think it's best in our hands. So how many places do you need to cover? How many places do you need to be? There's always somebody who wants a new line of service, and space is always an issue. Is there room for a cart? I'm finding now that when they remodel cancer centers and they remodel this, there's not even room for a cart. Will they provide a microscope, access to a plug, access to an internet port, water, electricity? Can we put it somewhere where it's not in use, where it won't be used as like a drink cart? So where I was at Cleveland Clinic, we had quite a few hospitals. So here was main campus. This is a hospital on the west side. This is a hospital on the east side. They had 7 hospitals, and everybody wants adequacy. How do you cover that? Well, telecytology has been something that's been proposed for almost a decade now. And you have to decide, what technology do you want to use? You want to use whole slide imaging? You want to scan the entire slide and then look at the whole slide image? It used to be slow and unacceptable. It'd take 10 minutes to scan the whole slide at 20 to 40x, but they're getting faster and faster. And if you do that way, the slide is there forever. You can, if I'm looking at it, I can call somebody and say, hey, can you look at this? And they can look at it too. Or real-time remote control. So is there any way we can use control the robot from my seat and drive the scope? So this is the first paper that I could find about telecytology. So Dr. Rob is an innovative pathologist. He's a genius. And he talked about using telecytology for cervical smear. And I have quite a few questions about this because this was done in 1996. And I don't know if some of you guys are in the room are old enough. This is not what a 1996 camera looks like. This is the 1986 camera. The 1996 camera were those little camcorder things with a little tape in it. So I don't know where he got this from. And if his wife was like, well, hey, what happened to our camera? And you're like, oh, I'm looking at some pap smears with it. She's like, whatever. But they hooked it up to a BH2 microscope. They had a RGB video camera. They didn't have there's no such thing as 780 and 1080p back then, or 4K. They just had one of those tube TVs. And they had a good concordance rate for pap tests. But there was a subsequent abstract of diagnosing cytology in the video telephone. So this has been around for quite some time. And the first clinical use of telecytology was by the AFIP, and they used it mainly for consults. However, it didn't really take foot in the AFIP because in the discussion, they say glass slides are just too perfect. Even though there was no discrepancies in the diagnosis, it was just too good of a system for them. They didn't want to go to this cumbersome telecytology. Subsequently, there have been quite a few people who've used it. There's many more papers now. We have somebody who used an Olympus camera and cell sense, and that's what we had at Cleveland Clinic for a while. We were trying to do that and validate it, but it was still quite slow. And then what happened with that is somebody would drive, a cytotech would drive the slide while you look at the screen. You're like watching a cytology movie, and sometimes it's hard if you don't have that control. There was a special paper that where at Geisinger, Dr. Monaco and her team had a multiple hospitals that had telecytology for on-site evaluations. And that's how they're able to reach all these far-reaching places in Western Pennsylvania to get these people a diagnosis. But if we talk about comparison of telecytology, there's static imaging where you take a picture and send it to somebody, maybe put it on social media or send it to a friend. That's very cheap. All you need is to put a camera on a microscope. You don't need any special software, but it's very slow and it's really not the ideal thing. Video streaming and robotic microscopy. So video streaming would be if somebody's driving it for you. Robotic microscopy would be as if you could drive it. And these things cost a lot of money. And whole slide imaging is probably where we're headed with this, because the scanners are getting faster. But the problem is for cytology, they say that we need that 3D image, we need that Z stack. So those will take up much more memory. It will take longer to scan. But as we progress with the technology, it's getting faster and faster. So here's an example of a robotic digital pathology platform. This is basically a microscope in a box with a robotic arm that controls it. And you could put it on a cart, and then somebody from far away can control it. Now, I always feel like you may not need this now, but I would recommend validating it as soon as possible, because you never know when some outskirt hospital says, we're opening up EBIS, or we have a guy that does EUS, let's start. So I would not wait to validate things then. I would do things now. That's what I'm trying to do at Mayo Clinic, get it all ready in case they open up some other center, and then I'm ready to go. I don't have to drive myself there. So now that we talked about the where, what is adequacy? Well, what adequacy is based on who is available. So if it's a pathologist available, they can give direct feedback and tell them, what each thing contains so they can do the procedure and continue. If it's a cytotechnologist, maybe they just say, tissue is present, enough or not enough. And it is really based on the situation. So every organ system is different. So EBIS, what are they sampling? Is it a lymph node or is it a lung mass? Also, how big is a lymph node? If it's a 2 centimeter lymph node, you're going to be looking for something bad. If it's a 5 millimeter lymph node, they're sampling it just because the guidelines tell them to. Maybe you could put your Santa Claus hat on and give them a lymphoid sample so they can move on. If the lymph node contains a tumor, can the procedure end at that time? Back in their 2010 and 2015, they would end the procedure, but now they want to know more about the extent of the disease. So once they found that contralateral lymph node, they may stop, but now they want to know more about what lymph nodes are involved in case they have to radiate. So I don't think the procedure stops then. If it's a small cell carcinoma, they would probably stop. For EUS, they would like confirmation that they have neoplastic tissue. So they don't want you to call it atypical or suspicious. They'll keep going until they have pancreatic adenocarcinoma on the slide, and they can tell the patient that. They don't want you to leave the room until that happens. So, I talked about EBIS, what is being sampled? Is it a nodule itself, or is it the lymph node? Is there a history of malignancy? It dictates the purpose of the case, whether they're trying to stage a lung cancer or if they're documenting metastasis. I can't tell you how many times that I walked into an add-on EBIS case and I didn't know what was going on. And I'm like, this looks like a non-small cell carcinoma. And then they're like, okay, good. And then I'm walking away and oh, the patient had a history of, ovarian carcinoma. Could it be that? And I'm like, actually, it could be. It was really ugly. So that history is really important. So here is what an ultrasound looks like. And the needle will come out there, and there's a balloon, and they can directly sample the lesion. You can see the needle going into it. So that way they know exactly what they're doing. The pulmonologist used to just do these transbronchial with no ultrasound. So they would know exactly where to put their thumb. So sometimes I see them teaching the pulmonologist how to do this. They say like thumb at 10 o'clock means you're going to be in 4R, and thumb down means you're going to be in this lymph node. To me, it's amazing. But they say you have to know how to do it in case the power is out and you still have to do an ultrasound. Now they have these robotic ultrasound machines that will hold the needle in place, and it's definitely less use of pectoral muscles. One time they let me hold the scope, and I tried to hold it. I didn't do it on a patient, but I just tried to do the motions, and you really need good pecs and shoulders to do this. I think with the robotic, you won't need that as much, and it gets good sample. It keeps the needle in place and allows them to do that. I don't know if the cytotechs would agree with that. What do you guys think? Plus minus, okay. So usually at the time of adequacy, they'll put the sample on the slide, and you'll make a smear, and then one will go into alcohol, so you can look at it later at your desk, and one will go into the diff quick stain, and you put it on the microscope right away and give an adequacy assessment and tell them what you see. There's also this part that goes here that you look at the next day. So what is a lymphoid sample? Well, many different authors have many different thresholds of what lymphoid samples are. Somebody said 41 lymphocytes. That must have been some mathematics that they did on that, or 5 low power fields with at least 100 lymphocytes, or abundant lymphocytes and pigmented macrophages, or if it's 30% cellularity. I don't think there's really an accepted answer. We just kind of know what a lymphoid sample is. So if you see a lot of lymphocytes here, you can say that this is indeed a lymphoid sample. You can go to high power and see that this is a polymorphous lymphoid sample. There's not a lot of small cells, not a lot of large cells, so you can just say lymphoid sample. It also depends on how big the lymph node is. So again, if it's 2 centimeters, you're looking for a legitimate sample. If it's really small, you may have to be generous so that way they can move on. And here's an example of a germinal center. Sometimes if I see that, I'll call it a lymphoid sample, just so they can move on with the procedure. So again, when for the procedure, we're talking about the pre-diagnostic. So if patient goes to primary care and they want to know what something is, then you can do the ultrasound with or without guidance. And then at that point, you can say adequate. And if it's benign, you can stop sampling the lesion and reassure the patient. So a lot of these freestanding FNA clinics, there's a very famous one in Tennessee. That's mostly what people go there for, is for reassurance that something is benign. Atypically, you may have to get more tissue, get some more from molecular. So for thyroid, we do ThyroSeq. I've been in places where they did Afirma. And to make a definitive diagnosis, then you have to decide if you need more for ancillary testing. So at the diagnostics stage, when you're confirming the diagnosis with minimally invasive means, it could be like a large metastatic tumor. They just need confirmation of what it is so they can start treatment. Or if the patient is not well enough for surgery, for example, like renal masses, if the patient wouldn't be able to undergo surgery and get a partial nephrectomy, they'll get it then. It could be used to plan surgery or staging, and you'll get a small sample, yet you still have to do a sizable workup on it. And for the post-diagnostic situation, if the patient already has a diagnosis, then you're doing adequacy to make sure that they have enough to do ancillary testing. You're trying to conserve tissue for more tests. So rather than, if you already know that it's lung cancer, you're not going to repeat TTF1 and napsin and other things. You're just going to save the tissue and just get ready to ship it to Foundation or Caris or wherever the oncologist wants. Or perhaps if there's a latent period, like if the patient had cancer a year ago and there's a new lesion, you may do a limited IHC panel to confirm that it's still that origin. So the why we do adequacy, to me, changed a little bit pre-pandemic and post-pandemic. I feel like pre-pandemic, we had better staffing. There wasn't this workforce crisis. It was easier to get an appointment. There wasn't as extensive a pre-op workup. We've kind of gotten away from doing the COVID testing, but now if you get a positive COVID test, you can't come to the hospital. I think that's kind of changed now. But post-pandemic, we've had staffing shortages. It's really hard to get an appointment. There's really less tolerance to have a non-diagnostic procedure. So, the published literature says that if you do rapid on-site evaluation, you can get more sensitivity and get a better specimen. It really allows if they're not getting anything, you can allow the clinician to redirect the needle, lets you triage the specimen and stop sampling when the diagnostic goal is achieved rather than guessing when to stop. So going back to our survey, why do clinicians request rows? Well, and why cytology performs rows. So these are like pathology perceptions. So cytopathologist perception, cytotechnologist perception trainee of why do we think they get the rows? And most people say ensure that diagnostic tissue procedure is achieved. But then also we say that to ensure that adequate material is collected and appropriately triaged. So they really, we all think that they want that hands-on from the lab to make sure that we're dealing with this tissue in the right way. And then, of course, here, 1/3 said to have cytopathology present to assist with collection, transport, slide preparation. So they can make slides, but they want us to do it. We do a better job, but there's some instances where they have to do it. They rather have us be there. And then why wouldn't rows be utilized? Well, most of the time it's always a lack of personnel or it's time consuming. So it's kind of a two-way street. The hospital, if they want it, you just don't have any personnel. Nobody can do it. That's just too bad. And then sometimes you get a pathologist who just says, we're not doing it. We haven't done it. We're not going to start. We don't have time. And then the logistics could be, there's multiple medical centers. The endoscopy suite is in another building. Some people say unnecessary lack of knowledge. So there's all reasons of why it can't. And in terms of the attitudes towards the performance of rows, most people have a positive attitude when it comes to thinking of it in terms of this is good for the patient, this is good for education, but they tend to have a negative attitude when it comes to the big one, which is reimbursement. Oh, I didn't put anything about reimbursement. Unfortunately, it's really not well reimbursed. When I was at Cleveland Clinic, we had problems getting all of our passes reimbursed. And then somebody from Geisinger published that they were getting a very low reimbursement rate for this. So it is a lot of work for pathologists and cytotechnologists to do that. But you're only really getting reimbursed for the 88305 cell block and core biopsy and any immunos you're doing. You're not getting any time. You're not getting reimbursed for the time you're doing it in most cases. I find that most of the time, if you have a short procedure, you'll get reimbursed. But if it's a long procedure that has like more than 10 passes, it's not going to get reimbursed. So how are we going to manage the shortage of pathologists and techs? How are we going to deal with new clinicians wanting service in different areas? So, interventional pulmonary fellowships and advanced endoscopy fellows, that's kind of a new thing. It's only been around since like 2005 and beyond. So now we get more centers like that are opening these fellowships up, and these people are going everywhere to all kinds of hospitals, and they think they're going to have what they have at a place like UAB. They have cytotech, cytopathology, but then they go to a hospital and that's not available, and they're like, where is all this stuff? How are we going to help them, or how are we going to help those patients? So even with telecytology, we discussed it, but it still requires a human interface. So at Mayo Clinic, Florida, we are trying to develop artificial intelligence to start doing this. Maybe have like a web cloud-based platform where we could, sample the pass, and then we'd have enough to do on-site adequacy, have enough to do molecular testing, have enough to do microbiology, really anything that the clinician would need without the presence of a human being there. Because, I think before the pandemic, it was scary to even think about somebody taking our jobs. But now with this workforce shortage, I think it's time to start thinking about this. So we have developed our own thing, really. There's a lot of companies out there that can do AI, but nobody does it in cytology. Everybody's been doing it in tissue. So we have this platform. So Dr. Z Akus is our computational pathology. So we call it Z platform. And we can scan slides here. We can annotate cases, and then we can put a label on it. So I would circle this and call it adenocarcinoma. I put a background box on it, so that way the algorithm knows like where to go, where to stop, and then it'll do deep learning and learn that this is adenocarcinoma. Now, deep learning is still a black box. Like, we don't really know what goes on in there. I mean, there are ways that you can deconstruct and find out exactly what it's learning, but I don't know if it's learning color. I don't know if it's learning nuclear size. It is definitely a black box, and it's hard to peel what's in there. But we're trying to make something where you can get like this. So this is a Grundium. Grundium is a proprietary scanner that has a 20x objective on it. You could scan a slide, upload it to the cloud, and then do AI and it'll tell you like what it is. So for the clinicians, if we use AI, then more clinicians could in remote places could use it. But if we reject it, it would restrict those procedures to places that have cytotechs or pathologists available. For pathologists, it will save us time, it will save us billing, it will allow us to do some outreach. But if we reject it, we need to provide resources for ever-growing demand for this. And for cytology, it would help resolve the shortage that's coming and that's already here. It would evolve their job and it will keep up with growing volumes. If we don't do it, it'll limit the scope and reach due to the need for a physical presence for us to be there. Where do we even begin? How do we even begin with this? Well, we have digitized slides. There's many questions like, what scanner do you use? Do you cover slip it or not? Like, do you guys cover slip your cases here? No. So like, there's a big difference between looking at a cover slipped case and putting a glass cover slip on and squashing the slides. Also Z-stacking, we're concerned if we're seeing that 3D configuration of the cells. Also annotation software, we have to teach this algorithm how to identify a tumor. We have to identify detractors. We have to run deep learning algorithms on a cloud that costs money. And cloud is the new gas. I mean, we're doing simple experiments and it costs $1,000 just for a month of using it. So this technology is already here. So I took a screenshot of my albums on my iPhone. So here's me, these fancy headphones, these are the same kid. This is a different kid. This is a different kid. This is my wife. This is my dad. This is my mom. Okay, so it can already tell, like this software exists. It can tell who is who. And if I click on my picture, it'll show me all the pictures of me. But then AI is also dumb in ways we don't know how. So this is my middle daughter, Gia. I type Gia, and it'll show me all the pictures of Gia. Wait a minute, my poor baby. Why do they put her as a picture of meatballs? Well, if you look on high power here, this is from a store called Giant Eagle, GIA. So they thought this was Gia. So it does dumb things, and like we do dumb things, but this is dumb in new ways. So, could we use artificial intelligence? Right now, AI and pathology use has been really limited. Most of the time, I think it's because they're using it for more beneficial things like Wall Street or, things that'll make money. But I don't think that pathologists have been involved enough to really tell them what answers we need. So a lot of the things that come out are about PD-L1, prognostic marker detection. Prostate and breast cancer have become very successful, but those people put a lot of work. There's a lot, like tens of thousands of annotations that went into that. So as pathologists, we have to say, what is the question? What answers are we seeking? What is going to help us? What's going to help the patient? So where do we even begin? Well, I'm lucky because the support came from the top and from the end user. So the CEO basically said, we want to push the pathology lab in the next decade. So here's money, make everything digital. And then our pulmonologist said, why can't we use AI to do this? And I'm like, why can't we use AI to do this rather than us go and go on all these ones? So, it's a big endeavor. And Neil deGrasse Tyson says that the race to the moon and the technology associated led to many innovations. So because we set out to do this in August of 2021, we've really come a long way. And the players involved were a supportive department chair and supportive pulmonologist, a director of cytology who understands adequacy for doing it constantly for 10 years. We have a good director of digital pathology who can evaluate platforms for us and tell us exactly what's good and what wouldn't be good. We have a computational pathologist. We have data analysts. We're trying to hire more people, engineers, software programmers, IT, willing cytotechnologists, digital technologists, interns who are willing to help with this. So, and here's what's kind of happened to our lab. So we go from, I got there in August 2021 and someone said, we should use AI for adequacy. Okay. So then we digitized surgical pathology and IHC, and that happened before I got there, and it got finalized after I got there. We do research and development on currently available scanners and annotation interfaces. We digitize cell blocks and core biopsy in cytology. We did a little trial of scanning smeared slides on different platforms and we annotate them on publicly available things like QPath or then we made our own, QPath is so cumbersome to use, so we made our own cloud-based integrated digital pathology and annotation and AI platform, the Z platform. Then we, acquired individual slide scanners with Z stacking, which is the Grundium. We find out that it works pretty well. We create, we enhance our Z platform and make it be able to annotate itself. And then now we're trying to get a multi-slide cytology scanner with Z stacking, and will hopefully become the first digital cytology lab in the country. Now, it's not going to be FDA approved, so we may not be able to use it for practice, but we'll be able to use it for research development algorithms. So what's the best way to do this? So first we tried with tumor nuclei identification in cytology using thresholding. So we're trying to develop a method to detect tumor nuclei in cytology slides. Right now, everything is for paraffin. If we can count nuclei, can we determine adequacy? And it should be quick and adequate. So we've used some of the publicly available things. I don't know if you guys have had a chance to play around, but there's the TIA toolbox. There's Dr. Mahmood has some algorithms. So we're like, let's just see if this works. So we plugged it in our cytology smear, and it didn't work at all. It's strictly for finding things in paraffin. So we decided we needed to start all over. So we had to develop our own vision-based method that can detect nuclei. So what we want to do is we want to get these samples, put it in an encoder, and have two things going on at the same time. See if we can find the nuclei, determine tissue and not tissue, determine blood and tissue, determine blank spaces in tissue, and find that. And then we want to try to classify it. So find out if it's adenocarcinoma, lymphoma, squamous cell carcinoma. Now, as I go around talking to people about this is what people really care about. Like, we don't care. We'll figure this out at our desk the next day. Can you just tell these people if we have tissue on the slide? Like, that may be enough. Like, you can sell that to places that don't have it. So again, I go back to this, and then here's an example of something that we annotate. So we have to draw a box, okay, and say that this is where we want you to stop. And then we have to carefully outline this group here. And I don't think we actually did a good job on this because there's like a little piece of blood in it. So that's going to mess everything up. And then we have a single cell of adenocarcinoma here. Now, it's so much easier to train a human. Like, we have cytofellows and residents. I could just point to you and say that's adenocarcinoma. And then you could find more just like this on the slide, and then we're done. It's that easy for humans. That's how advanced we are. But then we're training a computer to do this. It's very, very painful. So here's an example of, we annotated this and we run it through AI, and the AI gives us the coordinates, and it draws a box around here, and it successfully found everything we told it to find. So basically, it identified what we told it to identify. Good job. Here's an example. So we circled this and this and this, and then the computer circled these as well, but it did not circle this. So why didn't it circle that? We don't know. But for the most part, it got the fact that there are tumor nuclei here. And that would be good enough for the pulmonologist to stop. Here's an example of something that we did not circle, but if we asked the computer to look for it, it found it. So, I don't do this all the time. My computational pathologist and the data analyst people said, oh, it made a mistake here. I'm like, let me see. So I look closely at these, and I don't have a high power picture, but I look closely and it is tumor. So this thing is finding things that we didn't annotate. It's not that we missed it. It's just we didn't annotate it. Like, I don't want to annotate every single thing on the case, but that's very promising that it can find stuff that we did not find. So, we process a whole annotated slide of adenocarcinoma. We're looking up, seeing if the method is picking up real annotated regions, so true positives. Is it picking up nuclei that we did not annotate? That's really good. That's also a true positive, but not annotated. And is it picking up noise? Is it getting false positives? Yeah, we have a couple of examples of that. And is it missing any regions? No, it's not really missing anything. So here's an example of like things that I circle and things that the computer detects. Here's an example of something I circled, and then the computer detects this. Now, I don't know what it's circling here. I think I looked closely, and there are some tumor buried in there. You can see here. So it picks up things that I did not see. So there's several examples of that. But here's some unannotated true positives. So here's things that I did not circle, but the computer was able to find. So that's good. And it's good now, but there have been cases where I've been on an adequacy and I didn't see the tumor. And then the next day I see it. And then you sign the case out as, adenocarcinoma. Tumor is best seen in the cell block. Maybe it was here, but it's a little embarrassing, but that would be nice to have this. See, so it's finding tumor that I did not find. But let's talk about some of the false positives. So it's picking up like these folded blood things. And what is this? The marker. Yeah, it's picking up markers. So now I've been going back and training it. I make a new label, marker, pen. So you have to teach it to look at mucus, pen, all these different things that it would normally see. And I'm no stranger to this. So when I was training, I saw this amorphous blue stuff. And I'm like, what is that? What kind of tumor is that? And they said, this is ultrasound gel. Oh, so we learned, but I only had to be told once. I have to tell the computer hundreds of times before it'll learn. And it's funny that I call it the computer. I don't know what to call it. The robot, the computer, the cloud. So, we had a project and we presented at the US Cap. We had 33 different types of cases. And what we did is we made annotations, as many as we could, and we used 80% for deep learning. And then we used 20% of that subset for it to try to classify what it is. And we wanted to tell us, is this diagnosable tissue and what kind of cancer is it? Well, for the training set, it did pretty well in detecting tumor and non-tumor areas. And it did pretty well on predicting the tumor subtype. But oh, I have this backwards. I'm sorry. For the validation set, it had a good sensitivity for detecting tumor from non-tumor, but it did a really bad job of classifying. But our data is very biased to only a couple kinds of tumors, so we need to expand the tumor set. But when I tell this to people, they say, we don't need to know what kind of tumor it is right now. Just if you can give us this technology that would allow us to say that there is diagnosable tissue there, that would be good enough for what we need now. So let me play this video to see so you can see it work in real time. Why not? What's happening? Let me try opening it with a different program. Okay, so this is the Z platform. We have it connected to this Grundium scanner here. And it has Z stacking and it can do whole slide imaging and it uploads it to this application. Is the movie playing slow or something? No. Oh, so here it is scanning. It's scanning the slide there. So here you have like a overall view of the whole slide. And then you can select an area for it to really zoom in on and focus. So maybe if you're a pulmonologist or a nurse at a place that doesn't have a pathologist, you can focus on that area. And this whole slide image is uploaded to the cloud. So we're back to the scanner. We're back to our area of interest. Now we can look at the slide and we can put a square around it. We can run the EBUS algorithm. And then it identifies these as, let's see what the label shows, as adenocarcinoma. So it will work in real time. Now, this is a very like biased subset. We need many different kinds of tumors for it to really learn. Like I'm teaching it on like the same 30 slides over and over again, but it is working. But we definitely need to expand our the number of slides we have. We need to see if other users can use it. This application is going to be, we're trying to make a publicly available version of it so people can collaborate. So in conclusion, this limited data set shows that this could be helpful in determining tumor from non-tumor and tumor subtype. We have to annotate more things to exclude non-tumor things like pen, fibrous tissue, mucin, gel. We need to annotate different tumor types, more examples of tumor types. And this may help bring adequacy to places that didn't previously have it. And, now that I live, Ohio has rural areas, but now that I'm in the South, I see all these medical centers that don't have everything that we have, these big prestigious medical centers like this. So they need something for their patients, especially as they get practitioners who go out there. So we have to think about the underserved and reaching those areas as well. So we have a long way to go. We need more collaborators. That's also kind of why I'm here. I think this would be a good place to work on this. I mean, it's not easy, but we suffered through some growing pains, and maybe we could work together and do this with you guys. But for the pilot data from our proposed AI model shows promising initial results. We need more slides, more annotations. And then for the future directions, so we did all this on 2D images. We really need to repeat this on ZStack. So what's really exciting was when I was at the USCAP, I saw a lot of people would do very tedious work by like cutting through blocks so they can get different aspects of the tumor and get the 3D configuration. Well, I feel like cytology could be back in the spotlight because we already have the 3D configuration. We don't need that many slides. We can just scan different levels, and perhaps this algorithm will see things that we didn't see. It'll see it in a different way that we didn't see before. So really this adequacy is going to remain important. We can't just make it go away because we don't have enough people or enough resources. So just to acknowledge some people, Shanna Coletti is my cytology supervisor. Meredith Van Haar is a cytology quality specialist at Mayo. She's getting a data analyst PhD, so she has lots of good ideas. Dr. Deng is our director of digital pathology. Dr. Nassar is our supportive chair. Dr. Akus is our computational pathology. Dr. Johnson is the interventional pulmonologist who first said, let's do AI on EBIS. And I'm like, yeah, and we have some interns. Dr. Farrugia is the president and CEO. Like I said, it's really easy to get these things when they say, here's the money, make it happen. And then we got support from the Advanced Diagnostics Lab, which is the offshoot laboratory-based group that gives out money for innovative ideas. They gave us money for equipment and for some cloud, but now we got to find more grants. But I think we have really promising pilot data that'll help with this. So now I have time for questions and discussions. Now I went over a lot of the slides with the residents this morning, but I didn't think we have time. But we have 10 minutes for questions now. Yes.
Quick question on the workflow you showed with the single slide scanner, the gradient, the one on the finish. Who actually makes the smear? Is that either cytotechnologist made the smear or the clinical team made it?
The question for the Zoom people are, for the Grundium slide, for the Grundium scanner, who made that slide? So that was an old slide, but anybody can make a slide. So, nurses can make a slide, but there are things out there where you can, and they're using it in Indiana, you can insert the needle in a container, it'll swish it around and it'll stain it and make you a monolayer slide right there. We also want to play with that as well, because that would make a truly hands-free experience for everybody. If you can just put the needle in there, have a slide, put it on the Grundium, wait, circle the area you want to see, and then get assurance that it's what you think it is, what tumor you think it is. We're trying to look for a hands-free solution.
That the Grundium has a Z-stack?
It does. Well, actually, so Z-stacking also is a subjective term. So I don't know if it's like, I think it just scans it multiple times And then they have a proprietary thing that will stitch it all together. I don't know if it like is, I don't know, think it really goes up and down. Like it's just a bunch of images stitched together for, and it's their thing. So we're trying to form a partnership with them, although we're open to many people. We just want to see who will like cooperate with us, give us the APIs, that way we can work with it and work with it in our system. But yeah, that's their Z stacking. And I think the Z stacking is really important in cytology, because right now everything we think in 2D, all the books are in 2D. If we could think in 3D, I think we might open up a whole new world of and maybe even eliminate some molecular tests. So for thyroid, that's another thing I'm working on. We send so many cases, we call it AUS, and we send it for molecular and it comes back as nothing. Well, what if we could use artificial intelligence to maybe cut down on that, go bring it back to morphology instead of a $3,000 molecular test on things that don't need it? Yes.
Thank you, Dr. Nang. Excellent, taking our time. We have been doing e-books since 2006. And till now, we don't know exactly what is adequate and not adequate. And it's not enough. And I usually lie when they ask me what is adequate. I say, it's adequate when I think it's adequate. And it's actually it's a problem because we don't have some sort of clinical trial or a standardized way like in thyroid as well as pap smear that define adequacy through effort. It is just these 5 publications that they say, hey, this is adequate 41, or more lymphocytes than neutrophils and things like that. What do you use actually? What criteria do you use for besides adequate? And I'm saying this because in the last 2 or 3 years, we send our top technologists that says adequacy. We use pathologists used to go there, and they study, and we know what is adequate. Especially in cases where you have a lot of bronchial cells with basal cell hyperplasia and very scant lymphocytes. It's just really very difficult. And then the most important thing is, what is the gold standard? To what are you comparing what you call adequate? In the past, this lymph had to be taken out through the acinoscopy, and now there's no way to tell if it's really something for some.
Well, what I do is I just look for clusters of lymphocytes or germinal center tissue, and I'll call that adequate. I don't like to use numbers because sometimes there's just peripheral blood mixed in. But to me, the exciting thing would be we could use AI to determine this for us. Like, why do I have to count lymphocytes and bronchial cells to come up with some cutoff? Like, what if we just put the dang thing on the scanner and have it count clusters and germinal centers and lymphocytes, and then it could say, okay, of all the things that you call adequate, this is what it has in common. And then it tells us. And then we can say that, okay, this is what adequate is. That's too tedious of a project for a cyto fellow to do or a research fellow to do. And I think that is going to expand to other areas of anatomic pathology. I mean, it could take, whole years, a year's worth of project for a fellow and do it quickly, especially if it's something quantitative.
I used time motion study 2 years ago myself. I'm very fast. And it took me, and went in that speed for 4 minutes to just finish EBUS. I think if you use Vimbium or any other channel for 5 stations, it's gonna take like 2 hours of time to just do that. So you bring in absolutely all right. You improve accuracy, but you reduce efficiency.
Yeah, I totally agree with that. It's just my observation is that there's a tiered healthcare system here. So you can come to UAB and get the Cadillac service, but sometimes if you can't come here and you need something, there has to be something. So like with the COVID test, everybody wanted the NGS, but sometimes you got stuck with buying it at the grocery store and like, oh, they have tests today. Let's save these for later and you use them a year later and it says positive, but you don't know. So I feel like there's, of course, this is going to be the best quality here, but then there has to be something for people to use to help them elsewhere. And unfortunately, if we don't fix the workforce issue, there's going to be more issues like this, even at big medical centers.
Your experience is limited, but did you see any difference between different type of tissue? Was the system doing better, for example, picking up adenocarcinoma versus lymphoma, polygonal?
We're still working on the data. We only have a couple lymphomas. It's good at telling diagnosable tissues. So it's frustrating. I'm like, I want to subclassify these tumors, but then I had to back way up and teach it what a blank space is, and then teach it what a not blank space is, and then teach it what tumor is. So it's, yeah, we're still working on that. Well, the diagnosis is made. I mean, we have the core, so we make everything in conjunction. Well, we pull the slide. It's biased. It's biased towards things that we selected. At some point, we'll have to go back and put the slides that we said were non-diagnostic and see if it finds anything. Or yeah, it's biased. And that's AI in general. It's only as good as the information we can give it. Yes.
So back to adequacy. Does the, I guess, the final diagnosis or what you're looking for determine, may change different threshold for adequacy? I asked that from a heme path. They always do this bone marrow biopsy at 1 centimeter adequacy. It's crazy because it depends on disease. If it's leukemia, you don't need a 1 centimeter. And if it's metastatic tumor, God knows how much you need.
Yeah.
So does it change for you when you say they want to look for lymphoma versus they're looking for metastatic adenocarcinoma?
Oh, absolutely. I mean,
Change your criteria for adequacy.
it does, and it's evolved. I mean, we weren't doing molecular when I first started practicing. I mean, maybe you'd have a rapid EGFR test and it was high sensitivity, so you could do it on a little bit of tumor. But then once you find adenocarcinoma, like as they needed more tests, then you had to ask them to collect. You say it's adequate, and then you tell them to take more passes and put it directly into formalin, so that way we can do molecular. So yeah, it definitely changes on the disease. Yeah, it's confusing. But so many pathologists know how to do it. It's to me, like, after doing this, it's amazing that we can learn how to do this. So we should be proud of that. Thank you.
Yeah. Well, it was funny because it was nothing, one man on, or men on base, I found out. A new card.
Yeah, they switched.